Good afternoon, everyone. I'm Craig Corbin, and welcome to Telemedicine, Critical for Our Time. It's the second in our Broadband Bunch podcast, Zero Touch Learning Series of webinars brought to you by ETI Software. So glad that you have joined us. Of course, as everyone knows, today's topic is extremely important and timely. And given the unprecedented challenges that we face, perhaps never more so than right now. We have a great panel on tap for you today, and we'll introduce those folks to you in just a moment. But first, a couple of items that we wanted to make sure that you are aware of. Again, this is the second in our series of Zero Touch Learning Series webinars coming up later this month and into June and even July. We've got topics such as life post-COVID-19, the new normal, funding new networks in the era of social distancing. And yes, fiber networks are still being built, along with integrating telecom. What drives success? So a lot of great topics that we hope that you will join us for those discussions. Also, this reminder, this is very much an interactive webinar. We ask that you take part by submitting questions that you might have via the chat function today. Also, this reminder, this is being recorded for all those who are in attendance today for future reference. And again, if you have any ideas for other topics for future conversations or even panelists that you might want to hear from, we ask that you submit those to us as well. Well, again, we want to thank everyone who is taking part, and the most important topic now that I have is introducing our moderator. It's very much a privilege to introduce Heather Gold, a 30-year veteran of the communications industry. Heather, currently the CEO of HBG Strategy, previously served as president and CEO of the Fiber Broadband Association, following her tenure as senior vice president of external affairs and access management for EXO Communications. She graduated magna cum laude from Tufts University with both BA and MA degrees in economics, then earned an MBA in finance and marketing from Washington University in St. Louis. Our moderator for Telemedicine, Critical for Our Time, Heather Gold. Heather, the floor is yours.
Hey. Good afternoon, Craig, and thank you so much. I was just telling the panelists as we were waiting to join that I came from a medical family and I am the only one who escaped. But at this time, medicine and particularly telemedicine is front and center as we deal with the impact of COVID-19 and what is meant by telehealth, especially as we try to socially distance. So the Mayo Clinic defines telehealth as the use of digital information and communication technologies, such as computers and mobile devices, to access healthcare services remotely and manage your own healthcare. There may be technologies used from home or that your doctor uses to improve or support healthcare services. It encompasses many applications from low bandwidth usage email communications between you and your physician to high bandwidth usage such as reading x-rays or very advanced applications such as Cleveland Surgical Training Center. Telehealth is particularly desired in rural areas as they continue to lose access to health care due to the lack of physicians and the closing of hospitals. And this was critical before the onset of COVID-19. With the pandemic, patients and doctors everywhere, including, as we will hear today, from normally well-served urban areas, have had to find alternatives to the traditional office visit model. In addition to the regular rural health care universal service funding, the federal government has implemented additional programs under the CARES Act, where they allocated $200 million to be managed by the FCC in order to provide relief to healthcare providers. And it will be, unlike most USF funding, it will be administered directly by the FCC. And it allows healthcare providers to purchase communication services, information services, and devices that provide connected care treatment for the treatment connected care services for the treatment of COVID and other conditions related to the pandemic. This allows to free up resources to allow healthcare providers to treat COVID-19 patients and to spread the disease, halt the spread of the disease. We can get full funding under this program for eligible services and equipment, and maybe some of our panelists know more about that. Our speakers today will touch on all aspects of healthcare, particularly the challenges found in such rural areas. First, we have Kathy Wimberly, who's the director of Mid-Atlantic Telehealth Resource Center. TRCs are federally funded to assist telehealth program development and sustainability in order to increase access to quality care for rural and underserved populations. And TRCs really deal with the legal and logistical issues that are raised in telehealth, such as making sure that privacy and reimbursement rules are implemented properly. Next, we have Kathy Schwarting, who is the Chief Executive Officer of Palmetto Care Connections, a nonprofit telehealth network in South Carolina. It was founded in 2010. She works with existing telemedicine and telehealth providers to promote and expand their services, as well as with new and upcoming applications. And she also helps rural areas get the broadband they need in order to provide telehealth. Next, we have Dr. Jim Balshi, who is the Chief Medical Information Officer of the St. Luke's University Hospital System, a 13, am I saying the right number, hospital system in the Lehigh Valley of Pennsylvania. And last but most importantly, we have our frontline physician, Dr. Aaron Rogers, a practicing physician from Atlanta, who is a leader in the treatment of nasal and sinus orders. And with that, I'm going to ask each of the panelists to give us a brief overview of their area of expertise and how they're impacting the availability of telehealth. Kathy Schwarting.
Thank you,
You're
Heather.
actually going to start with me, right?
Yeah, I
Those
think
are my
it's,
slides.
yeah, it's up, yeah, go Kathy.
Yeah. So this is Kathy Wimberly, and I'm over the telehealth resource centers. And just in front of you is a map of the telehealth resource centers. So we are actually funded by the U.S. Department of Health and Human Services Administration, so HRSA, and we cover the entire U.S. as well as the U.S. affiliated Pacific Islands. My center, which is a regional center, is highlighted in the dark purple, and so we are Mid-Atlantic. We serve a 9-state region, and each of the regional resource centers really are here to provide technical assistance, to provide answers to questions, to provide operational assistance. So for any provider or organization who wants to use telehealth as a way to increase access to care, we are kind of the no-cost consulting firm, essentially. So you can reach out to us and get everything from your, basic questions regarding, how do I get reimbursed, all the way to, we're starting a telestroke program, or we're starting a school-based telehealth program, and help us kind of navigate all of it from, the technology that we need to, and the requirements, all the way to, how do we develop protocols and workflows and diagrams, and how do we do all this in terms of policy. So we take care of all that. We also have 2 national centers. One is the Center for Connected Health Policy, and they're the Health Policy Resource Center. They are national in scope and probably have the best database in terms of state as well as national policies regarding telehealth, and great place to kind of check out what's going on in your state as well as around the country. And then we have the TTAC, which is the Telehealth Technology Assessment Resource Center, and they really look at technologies from a broad perspective, hot innovations that are coming up, as well as toolkits for video conferencing, toolkits for otoscopes, stethoscopes, all sorts of digital technologies. So next slide. So like with all telehealth resource centers and all of America, I think the slide or the graphic that I think really resonated with me is that in the blink of an eye, telehealth and healthcare have become synonymous, and that's really what COVID-19 has done. It has it's basically led the digital transformation of everyone's company, whether you are in healthcare or you're a hospital or health system or you're a private provider. And I think this is where we have really seen the uptick in terms of utilization. It's at the private provider level. Typically, it's been kind of hospitals and health systems that have done telehealth, and more to the landscape of, facility to facility, kind of the traditional hub and spoke model. We had seen the direct to consumer happening, but it was not huge, and certainly not in the primary care space. And suddenly we had this influx. Why? Um, a lot of it, I think, has to do with the policy barriers that have been lifted as a result of COVID-19. So obviously, reimbursement has always been a challenge because every payer has their own policy, and it makes it very complicated. So you have, Medicare, you have Medicaid, and you have private payers, and they all have different policies that you have to navigate. But a big part of this reimbursement challenge has been that for the most part, most payers have not been reimbursing for direct to consumer care, so the patient at home. And so with COVID-19, there's really no choice but to reimburse for patient at home because patients are not leaving home. And so all of a sudden we're seeing this influx of care being delivered while the provider is at home, while the patient is at home, while the provider's at the office. I mean, it basically is everywhere. And that's really been our goal and our vision for telehealth, is that there's no reason why patients can't get care anywhere, wherever they happen to be. So the other policy restrictions that we really saw lifted were related to licensure. We saw a freeing up of that. So there's a case to be made for, states having control of the licensing and being able to um, be responsible for bad practice of medicine, and bad practice of medicine is bad practice of medicine. And that's really been a state responsibility. But we're also seeing that particularly in rural areas where you're having a hard time getting providers, and particularly specialty providers, the loosening up of some of those restrictions to help hospitals, to help in areas where there's just a great demand, particularly with COVID. It has helped significantly. We've seen policy restrictions kind of waived related to HIPAA. The HIPAA has not been waived, but the kind of enforcement of HIPAA has been waived during the pandemic. So what we're seeing is, people able to use their devices and able to use your, consumer-based video conference platforms, which has made it a lot easier for providers, but it will also create a challenge of very sloppy telemedicine when things go back to, or hopefully may not revert completely back to, but starting to go back to normal. But we've also seen a real challenge has been with prescribing controlled substances. And so, we've waited a decade for the DEA to figure out the whole regulations and restrictions around controlled substance prescribing with telehealth. And with the blink of an eye, they said, hey, go ahead and do it. So, this is what has happened in the top policy landscape. And so we've really forced both the patient and the provider to get beyond that status quo. But what it also has done is created challenges with broadband. And I'm sure Kathy Schwarting will talk more about it, but broadband, if you can't get broadband into your home, it's very hard to do telemedicine into your home. And so that has been a big challenge. Most of the previous kind of FCC USAC efforts have been more making sure that facilities have broadband access. And so that has not addressed the patient to the home broadband access. And that's where we're really finding some significant disparities and challenges with rural areas and even some urban areas. There are some areas that are right outside of an urban center where you cannot get broadband. And it's both the last mile fiber as well as the cellular infrastructure in our country. So those are definite challenges. Next slide. So this slide just gives you a little bit of a grasp of what has happened just from our perspective. So on the left side, you'll see the technical assistance encounters that all 14 of the telehealth resource centers fielded in all of calendar year 2019, and that was 4,039. The right-hand picture is just my telehealth resource center. So one telehealth resource center over 2 months, April and May, we fielded 439. And that's been an 800% increase from the previous time period of the previous year. So, clearly the demand is suddenly skyrocketed. Every provider in the country, including every private provider, has been contacting us saying, hey, we need to do this. We need to do this yesterday. How do we do this? Help us do this. Help us navigate it. And so it's truly everything from, help me find some technology I can use to help me find the policies that support my reimbursement so that I can stay in business. And those first 2 weeks were really challenging because CMS was still kind of reinventing the policy as we were going, and so it was changing pretty much every week, and sometimes twice a week there would be new guidance. And so providers would call, and then you go, oh wait, that just changed like 10 minutes ago, hold on. And so we really had some panicked providers saying, I got to stay afloat. Like my office is going to close if I can't figure out how to do this and navigate the reimbursement piece. And so I think we've finally settled a little bit now, and things are starting to move. But these challenges, I think, are going to be ongoing because the pandemic's not going to go away. The disease is not going to go away anytime soon. And so patients are still going to be hesitant going into offices and facing exposure. Providers are going to become exposed when they're in their healthcare settings and not be able to work from the office, even though they may be feeling okay, they may have tested positive. So they're going to need to be able to see patients from their home or wherever else they are in quarantine. And so this is kind of this challenge that we're going to be navigating, and I anticipate for more than a few months. Next slide. Okay, there we go. So just to for those of you who are not familiar with the telehealth resource centers, our main website is telehealthresourcecenter.org, and you can reach all the national centers and all the regional centers by going there. And so there is a huge map when you get to the telehealthresourcecenters.org. If you click on the state that you're in, it'll pull up the form for that state, and there's a very quick and easy request technical assistance form. You can select, it'll automatically go to the resource center that serves your state. That's my contact information. And if you are in my region, our website is matrc.org, and we have developed a COVID-19 toolkit that is fairly comprehensive, from everything from telehealth etiquette to, how do I do a visit, to how do I code, and how do I document a visit, to what do I do if my patient needs interpretation. We've really tried to cover all of that in this toolkit, and so it's open to anyone. We welcome you to use it as needed. So thank you for having me.
Kathy S.
So thank you. And Kathy, that was great. And I will add to the fact that the telehealth resource centers are really great resources. I'm not in Matrix or Kathy Wibberley's target area, but she has been wonderful to us. They have a lot of great information for anybody looking for some telehealth information. So I'm the CEO of Medicare Connections. We are a telehealth nonprofit network, and our primary focus is to make sure that rural areas and underserved areas have access to quality healthcare services through telehealth. You can go ahead and forward the slide. So this was really pre-COVID-19. The need for telehealth has significantly changed since the pandemic, as everybody knows, but before COVID-19, clinical shortages, not having enough providers to provide these services, our increased aging population, the fact that millennials are so tech savvy and they don't like to wait. I have two of them in my household. They don't like to go sit in a doctor's office for an hour and a half and wait. The reduced travel time, transportation cost, all of these were factors in telehealth. But I'll be real honest with you, pre-COVID-19, it was really difficult, and Kathy could probably add to this, but it's been challenging to get rural providers to actually use telehealth. It's new, it's technology, they have to train their providers. Most of the providers that we work with in the rural areas, and we're going to touch on this in a minute, don't really have good access to broadband. So there was a lot of concern from the provider's perspective. And then a lot of unknowns, reimbursement, licensure. making sure somebody in their office was trained to do the coding correctly. So all of these sort of lended itself to a slow adoption for rural providers, in my opinion. Since the pandemic, things have completely changed. Within the first 2 weeks of COVID-19, I think we issued over 600 Vigio accounts. And Vigio is a telehealth platform that's easy to use. We have set up over 300 providers to use a direct-to-consumer product called Doxy.me. So now everybody's on board and nobody can keep up. Kathy can't keep up. We can't keep up. Every provider wants to utilize telehealth. We've had some issues in our state with implementing the telehealth, such as with Blue Cross and Blue Shield in South Carolina. They require a credentialing application. So each new technology that a provider chooses to use has to go through the credentialing process with this private payer. So challenges like that have been very interesting. I don't know that we would have seen that as so much of a barrier pre-COVID-19, but the pandemic has certainly changed things. As Kathy said, we did a webinar, I think 2 weeks ago, for rural healthcare providers, and we had an FQHC and an RHC present on how they had actually implemented telehealth, and we talked about the reimbursement. The next day, that reimbursement had changed. So the reimbursement for these providers is almost fluid, and they have to, it's a lot for them to keep up with every day. So we have seen that that has been a way that they have used our services, is to kind of keep them updated with the changing in legislation, the changing in reimbursement. And that's been a big thing for us. One thing that we have seen since the pandemic that was really a surprise to me, and Kathy, I'm not sure if y'all have experienced this, but we have been somewhat bombarded with consumers and patients. I've had consumers to email us and call us wanting to know more about telehealth. Some of them can no longer go into the practice to receive, say, physical therapy services. They're being referred to receiving those services via telehealth, but up until recently, physical therapy was not covered by Medicare. So the patients were calling us wanting to know how they could advocate for better telehealth reimbursement, because they were being told that they were going to have to pay for it out of their pocket. So I'm not sure, Kathy, if you've seen any of that, but that's been very interesting to us.
Yeah, we have seen some of it, not quite as much as probably you have, but we definitely have seen more patients reaching out.
Yeah. So next slide, please. So PCC is also the administrator of our state's Broadband Consortium, and we help our healthcare providers to receive the subsidies from the FCC's Healthcare Connect Fund program. This one thing I will say about South Carolina that I have been very pleased with is our providers seemed very well equipped to handle the telehealth that they've had to implement. I think because we've done such a great job over the last 4 or 5 years, making sure that they had adequate broadband just for day-to-day activities with telehealth. So most of them, I feel like, were adequately ready and prepared to handle the telehealth opportunities. I'm sure most of you know, but the FCC came out with a really great program maybe 6 weeks ago, and that is a $200 million telehealth program. We have helped a lot of providers to apply for those funds. As of right now, unless it changed over the weekend, South Carolina has not received any funding thus far, but I think the last time I checked, only $50 million of that $200 million had actually been awarded. So there are a lot more funds to be awarded, and healthcare providers from all over the country are applying for these funds. Those funds are not for broadband activities. They're not to fund circuits. They're actually for telehealth devices and technology and infrastructure. So as Kathy said earlier, I think the FCC has primarily in the past been focused on making sure that healthcare providers have had adequate broadband to do telehealth. And now that we are into the pandemic fully, there is a tremendous challenge in our residences. So I'll give you an example. We have a rather large FQHC in the PD region of South Carolina that within the first 2 weeks of COVID-19, once they had implemented a telehealth platform, they had done over 600 virtual visits, which was really big for that healthcare provider. But they had performed double that number in phone call visits because of the lack of access to broadband in the homes. So not only do the homes have a lack of access, but some of the patients don't have phones, or some of them don't have adequate phone coverage. Maybe they're buying minutes from Walmart or wherever, and they run out, and so they can't do a telehealth visit. That has been a particular challenge in our state. So we're trying to, the FCC has been really great about trying to find new ways to fund broadband. We've seen a lot of work with our service providers. I've had lots of calls with service providers, and I think the pandemic in our area has really urged them to come up with some strategies as to how they're going to expand broadband into the residential communities across in their region that they serve. We actually, back at the end of 2019, partnered with our hospital association and our Office of Rural Health, and we mapped out the state's broadband access, which has been really great for us. So I actually had a person from Boeing International emailed me this morning, and she had looked at the maps on our website and was particularly interested in one of our rural counties. So if you pull up these maps, you can see where we actually have broadband access in the state and the areas down to the census tract level of where we have a lack of access. So these maps have been used by our governor's office during COVID-19 to help plan on how they're going to fund better broadband. So that has been particularly helpful for us. Next slide, please. So PCC Program Support, we are here to support any rural provider in the state. We help them identify what telehealth services they need. We help them with their broadband needs assessment. We make sure that we can help them get the adequate connectivity that they need. Clinical workflows, that has not changed. We actually have set up a lot of nursing homes with telehealth, with a virtual platform for telehealth during COVID-19. I reached out to a physician that covers about 10 nursing homes down in our rural area. And in about 4 weeks, he had not been able to actually visit any of the residents in the nursing home. That cannot occur. And if telehealth can help him with that, then that's exactly what we need to do to enable him and those nursing homes to use that technology. So I think the biggest thing that we've learned in our efforts is telehealth is great, but it is not going to work if we do not have adequate broadband in the homes, in the local provider offices. So there's a big push in our state to make sure that we get better broadband coverage.
Can I ask one? Thanks,
Yes.
Kathy. Before we go to Jim, can you just tell us what FQHC? Yeah.
I'm sorry, you're right, I'm talking to service providers. So an FQHC is a federally qualified health center. They receive federal funding to be able to provide services. They don't turn patients away, and they are particularly known as our safety net providers across the country.
Great.
Sorry,
I bet everybody else on the panel knew that, but I didn't. Jim.
And that's it. I think that's my last slide.
So thank you for having me on this really interesting webinar, and it's good to hear both Kathys talk about issues that we've dealt with in the St. Luke's University Health Network. And just to be clear, we're not quite 13 hospitals at this point, but that could change even this week. There's our presence in Northeast Pennsylvania is we're the third largest metropolitan area or population area in Pennsylvania, behind Philadelphia and Pittsburgh. we are Allentown, Bethlehem, and Easton. And although our main hospital is in Bethlehem, we have many satellite hospitals that extend out into the rural community, especially into the coal regions of Pennsylvania. In fact, one of our hospitals is a former state mining support hospital. It's called St. Luke's Miners. And our most recent hospital is a joint venture with the Geisinger organization in Orwigsburg, Pennsylvania, which is literally in the middle of almost nowhere. And people recognize it because we have one of the largest Cabela's on the planet nearby. And so that's we're both urban in Allentown and Bethlehem and Easton, and we're suburban and rural. Our presence in the telehealth space was literally a very small direct-to-consumer, on-demand telehealth program. If someone felt they had the sniffles, they wanted to talk to a doctor, they could pay out of pocket for a visit. We had essentially zero elective scheduled telehealth outside of the inpatient consult. Now, we had that process, of course, with stroke and with many of our specialty practices into our rural hospitals where travel time would have been prohibitive, or just having enough specialists to cover all of those hospitals was prohibitive. But on a day-to-day basis, when COVID hit, we lost, we typically have about 6,000 outpatient visits a day in our network. That dropped to about 2,000 of the most critical patient encounters happening in an office practice. But people just decided, I'm not going to the doctor's office for whatever reason, whether we were shelter in place as a government regulation, or they just recognized that they didn't want to sit in a waiting room. And at the same time, maybe their daughter or son who would normally transport them to the physician's office wasn't available because they were sheltering in place. And so it really forced a vacuum. And we took so our organization has close to 1,500 employed providers who had no experience outside of an in-hospital consult with dealing with telehealth on the patient ambulatory basis. And we were able to train 1,900 people, including office staff, in a telehealth process in 3 days. And we, over the course of 5 weeks, we hit 130,000 televisits for our network. In transparency, a lot of those were telephone calls that now were reimbursable, but also for technical reasons, because many patients couldn't figure out the televisit concept. They couldn't make it work on their whatever devices they had. If they were elderly, and this is not an elderly problem, we had 90-year-olds complete televisits with zero problem, and we had 35-year-olds throw up their hands and say, just call me on the phone. So it was not specifically an age thing, but a lot of our healthcare is with an elderly population. So there was a challenge in getting the patients up to speed. Our organization has a history of working with Microsoft, and we adopted the Teams platform as a telehealth platform, but recognized that in this critical time where we had just essentially a stop of the revenue stream in our organization, that we would take any port in a storm, and whatever technology you could do to connect was okay with the government and okay with payers, but recognizing that that's not going to last forever, and that we wanted to build a system within our network that would provide a HIPAA compliant and really a secure platform going forward, and it would give us the full breadth of experience. So we're doing a lot of work on the ground to improve the patient's acceptance of a HIPAA compliant platform outside of FaceTime and Google Duo. What we have seen is a tremendous acceptance where we had no idea how this would go over, but providers who don't necessarily like when somebody moves their cheese, we're suddenly saying, hey, this works. This actually was pretty good. And we had patients who were reluctant at first to be really appreciative of the fact that we could do this, and they felt very comfortable with the visit. I think it was eye-opening on everybody's consciousness that this was going to be an important thing in the future. And there are hundreds of different examples of why this should have been the norm pre-COVID. And I appreciate the work that Telehealth Resources has done, and that practices like Palmetto have been able to do. We in Pennsylvania and Western New Jersey have suffered from payer inequality or payer non-parity. We're one of those states that has held out and not pushed for parity payment. And it was clear as soon as the payments were available, suddenly the platforms worked, and they worked. And you know, I think as a physician, as a provider, we all recognize so much of what we do is not necessarily hands-on. It's a lot of talking to patients. It's a lot of explaining to patients. It's explaining to family members, and the ability to bring multiple people into the conversation easily has really been a boon to I think better patient care. We have the ability now to bring our translating services into the televisit. We have the ability to bring the daughter at work, not today, but next month maybe, into the visit with the provider and the patient. And that's just invaluable. So we're very excited about that. If you go to the next slide, please. So we had some experience with on-demand visits. We had literally no experience with scheduled virtual visits, but that has exploded and has been extremely successful. And we see the expansion of telehealth into a virtual health environment where we will be the bridge between the ambulatory office visit and the inpatient hospital visit. And that entire space is still evolving and demands a lot of broadband services to handle all of the patient devices that will be on our menu of services in the future, from chronic glucose monitoring to temperature monitoring to probably 10 or 12 different devices, pulse oximeters, heart rate monitors. I think there is an evolving industry of services that we will be able to bridge the gap between the ambulatory visit that used to happen once a year or twice a year down to the hospital encounter, and now provide us with a more continuous care experience for our patients. And the struggle with access in our network into the rural environments has been dragging that cable or that fiber as it was in the past. Our latest hospital, the Geisinger co-venture that we did, it took us nothing short of 6 to 8 months to work with various ISPs and internet companies to drag fiber into that location so that that hospital could be part of our gigabit loop of fiber that we connect all of our facilities with. So I'm curious as to the alternatives to struggling with dragging fiber into a rural area. And are there efforts, and I'm looking forward to efforts, especially in the television white space. And I'll just leave my comments there, and maybe some of you can speak to that later.
Thanks, Jim. Aaron, let us know how it's going as a physician on the line.
Well, thank you. And thank you very much for having me this afternoon. I'm glad to be able to chat with some other like-minded folks. Unlike Dr. Balshi, I'm a physician in charge of a very tiny office. So we've got basically 4 physicians at our office. We have a few mid-level providers. We provide some ancillary services like hearing aids and audiology testing and speech therapy. About 30 to 35 employees or so at any one time hanging around our office. We've got 1 office location. We're in a suburban, sort of a near suburb of Atlanta. Atlanta's just down the road. I can almost see the sign from my office. And we did basically, we're surgical subspecialists in ear, nose, and throat practice. And we basically do our business and make money by seeing patients in person. Now, a lot of that is sort of medicine-like counseling and discussion, reviewing records, reviewing charts, determining the next best step, doing some medication management, looking at images and that sort of thing. But a lot of it's actually doing procedures to our patients. So it was really a hard lump to take back in late March when we basically had a hard and fast lockdown of our state and of everyone's sort of willingness to come into the doctor, and with good reason at the time. Practically every thought leader said, don't go to the doctor's office right now unless you might have COVID, and if you have COVID, still don't go to the doctor's office unless you're dying. So it was really a challenging time for us, and just coincidentally, it's my daughter's last day of class before they got shut down. She brings home a cold, and I get a fever on the very first day that we started checking for fevers at our office. So I myself get sent home and have 3 days to wait on my own COVID swab to turn up negative finally, but I have 3 days to sit with my daughter in isolation in our garage apartment, trying to figure out what the heck we're doing with our practice the next couple of months while this pans out. And that's when we started looking closely, or I started looking closely and sort of leading the way here in our office to how we can get people online and start doing some of these discussion visits by telephone. If nothing else, just as a means to maintain our goodwill with our patients, so that when this nightmare finally ends, they will come back to us and they won't go to the next guy. I myself saw some emails and flyers where other practices, dental offices and ear, nose, and throat practices that are competitors with us basically locked up the doors and shut down. They said, we're shutting down to anything except emergencies. There's 1 doctor on call. You can call, for 6 weeks or 5 weeks or so at the time. And we didn't really want to be that practice. We wanted to maintain some more regular communication with our patients. So this telehealth was at least a way to maintain communication, if not try to do some real medicine, and it might even have a lasting impact on our practice. Right at first, we were sort of threw our hands in there and said, I have no idea how we're going to bill for this. I didn't know telemedicine paid anything. Telephone calls don't pay anything, by the way. There are codes for that, but it probably costs you more to try to collect it than otherwise. But then there was a lot of relaxation federally and through some of the private insurers, who basically, it looks like the billing and the billing for telehealth visits was going to be a reasonable thing, probably reasonable for an office with a smaller overhead than our office, but at least a reasonable thing, sort of equivalent to an E&M visit, which is good. But again, our practice is largely procedurally based, so probably this is going to be something difficult for us to continue at the same pace going forward. But over the last several weeks, since that late March time period, every provider in our office has done telehealth visits, including our audiologist, who has done basically hearing aid discussions and tinnitus discussions with patients, our speech therapist, who's done speech and swallowing therapy over the telephone or over the audiovisual chat mechanisms with our patients. Every physician and every physician assistant has maintained communication in some telehealth schedule. Up to our peak, we're probably doing 120 telehealth visits a week with our little office, which is great. That's replacing probably about half the visits that we would ordinarily have in a week's time here, maybe a little bit less than half. So it's replacing some and replacing a little bit of the revenue, but I think more importantly, long-term, is just maintaining the relationship and some of the continuing care. Also, from our standpoint, it's good for some of our referring primary docs to know that we're still here for their patients and for them. So that's kind of another issue for us, was maintaining that goodwill. We didn't just completely close up shop there for several weeks. Still, it's definitely something that's this doing telehealth for weeks and only just recently starting to open up to the real world where I am today, seeing patients in person live, definitely taking a big hit on the top line for us and subsequently the bottom line going forward. So it's something we're going to try to control a little bit better and sort of maintain somewhat. We do some things that I think are well suited for telehealth in the future, but a lot of these visits are subsequently converting back into regular office visits going ahead. A lot of my experience also with our office, I'm one of the physicians that's basically the kind of the most tech savvy, the most interested in the technology. And we have always, like a lot of probably small businesses and medical practices that don't have tech as sort of our central core competency, have always had sort of a hunger for needing more and more tech, it seems like. We always need something faster, more reliable, smoother, et cetera. So we have always underestimated, how much money to spend on computing services and internet switches and ISPs and whatnot. We can go to the next slide, maybe. Over the years, what I've really come to notice is that you can have a fairly fast quoted internet connection that you get quoted from one of the ISPs locally, but you can stream YouTube videos all day with that. You can download your emails all day without a hiccup. You can have really no problems in a lot of those sort of demands that allow the network to buffer a little bit on its way to you. But where you start getting to a lot of trouble, or where we start seeing a lot of problems, is with we have a cloud-based EHR. So every computer user here is coming into the office and logging on in real time to a server out in Texas, in our case, to get onto our EHR provider, and then interacting synchronously with that server remotely. So we get a lot of problems, not only with what we all just sort of generically thought was the speed of the network, but really what seems to be some of the quality of the network also. So really, we have come to find that you really need a much more sort of commercial grade, high grade, dedicated line, even to a small physician's office, in order to run some of these high demand synchronous applications, like our EHR server, for instance, being off-site, like telemedicine that allows a nice smooth picture getting to the patient without a lot of choppiness and cutting and breaking in and out. And then also almost everything we do is sent in by some encrypted protocol, which also puts more and more demands on the network system as well. So that's been one problem for us that we've kind of constantly had to ratchet up and adjust yearly with our ISPs, is getting sort of a smoother connection, not just speed, but really less and less turbulence on that network, which is my understanding kind of has to do with how dedicated of a network connection you have. And then finally, 30 or 35 employees in an office. Every employee's got a computer connected. We have several other computers that run sort of ancillary things like CAT scanners and ultrasound machines. Everyone's got a digital phone. We've got several network printers. There's all this sort of internal network traffic that really puts big demands on the system also. And 9 out of 10 times, whenever there seems to be some kind of an internet slowdown or hiccup happening at our office, it's not so much the actual ISP out the door. It's actually something going on internally. And that's despite having kind of all the big name firewalls and big name switches and everything else we have here. There's always sort of a hunger or demand for more and more speed and more, I guess, control and network infrastructure. So it's something that the sort of little client, the little end users like me, should not really underestimate. It's hard to underestimate how much real smooth, network information transfer we're going to all need in the future. Going forward, in Georgia and in my city and in my state, we are opening back up medical practices. We're probably about 50% back to normal right now. We expect that to continue to increase, but we will have some slots and schedule persisting for the telemedicine visits. And Ms. Werberly, I may be calling you tomorrow to get a lot of input on and answer all the questions that I spent so many hours and days chasing around earlier this year. Maybe you have faster answers for us, but that will be something that we continue in some capacity, even at a procedural subspecialist office. So yeah, I really look forward to some of the discussion and further commentary today. And thank you very much for having me.
Thank you, Aaron. And whether you knew it or not, you just made the ad for all fiber networks. where they all, and I think everybody else will agree with this, they always advertise the fact that it's a gigabit up and a gigabit down, or it's synchronous and low latency, which is
Right.
what you're complaining about. So we'll have to find out why you can't get some more fiber in Atlanta, but I think that's function of your network providers there. We have time for a few questions. If some of the attendees would like questions, please type them in your chat boxes, and I will be able to see them online and send them out to the panelists. I have a couple to start with myself. What have been some of the pluses and minuses from increased telehealth usage? Aaron, have you seen any pluses, or primarily it's been a gap?
So it's actually rewarding and I think efficient for me to actually have several of these, kind of Q&A type of visits lined up one afternoon. So, I mean, our practice and our style here, we really do usually spend significant time with the patient, and we do procedures and things, but for half the patients, it's really about discussion and about sort of treatment planning and getting them to understand a lot of things Dr. Balshi mentioned earlier during his presentation. And it is actually, I think, rewarding. I can do 2 or 3 or 4 visits in a row and kind of have this discussion and plan laid out with the patient and get things figured out and planned for the next few, next couple of months down the road. I think that's very rewarding and beneficial. Some of the, the minuses are many. Maybe we'll talk about those later on as well.
Jim, what about you?
One of the things that comes to mind is I grew up in Bethlehem, which was the home of Bethlehem Steel. And if you are familiar at all with any of those big old brown industries like steel, the community around it was a bunch of immigrant ghettos. We had the Polish and the Slovaks and the Italians and the Irish and the Germans, all on the south side of Bethlehem. And my father was a physician, a primary care physician for 10 years before he became an ENT doc. And he used to say to me, I've been in every one of these homes in South Bethlehem. And the funny thing is, with telehealth, we're re-entering all of those homes again. And that's one of the things that I think has been a tremendous positive. And I think what providers have found to be fascinating is seeing the world that their patients live in. It's, maybe not the most important thing about taking care of them, but it certainly becomes part of how we view that patient and how we build that trust with the patient. So that is a positive that maybe doesn't get talked about enough, but it truly is. I mean, I've looked at everybody's background as we've learned with these video conference calls, is that you get a larger sense of the patient, seeing their dog run by or their kids climbing up on mom's lap, and it's a different intimacy. So that's a positive.
Kathy, I see you nodding your heads. Have you had the same feedback?
Yeah, to piggyback off of that, I would say one of the positives for me has been the response of the patient and the consumer. And I think before COVID-19, a lot of folks were very weary of a telehealth visit. They were afraid of the confidentiality, the privacy. They really would not be able to talk to their provider the way they normally do, to talk about some things outside of what the visit's about. And I think they have been very surprised, particularly the elderly population. I can't tell you how many folks they finally know what I do. Before, when you tell people you worked in telehealth, they were like, what is that? And, anyway, but people text me and email me and they'll say, Kathy, my 86-year-old mother had her first telehealth visit and she loved it. She didn't have to leave her house. She didn't have to call me to come pick her up and drive her to the doctor's office. She didn't feel so much like a burden to her family. She, I went over, I showed her how to use it. Her second visit, she did it by herself. So I think a positive has really been that this has been very good for the patients. And I think they have, some of them don't like it, but the majority of them have responded very favorably, I think, about using telehealth.
Kathy, have you had the same kind of feedback?
Yeah, we've definitely heard the same thing from both providers and patients. You know, now that we've tried it, we actually like this. And I think everyone I've talked to has said, yeah, we want to maintain some level of this even when things go back to quote unquote normal. And so, you know, I think there's definitely been that. But an interesting thing that we have heard over and over again, and I'm on a telehealth work group for COVID-19 in our state, which is Virginia. Almost uniformly, everyone has said we have decreased our no-show rate with telehealth. And you think, well, probably could have told you that, but you know, it's interesting to actually hear that from a number of providers. Whether it's hospitals, health systems, private providers, all of them have pretty uniformly said, you know, our patients are actually showing up for the telehealth visits, where in the office it would have been a much higher no-show rate. So I think that's a huge positive.
So those do not show rates don't help people not show up, huh? How difficult has it been to get funding for these applications? Have you all, I'm particularly interested in Dr. Balshi and Dr. Rogers, did you have to expend additional funds to get up and running or expand your telehealth networks? And did you have any problem getting funding for either the network part or the application part?
Aaron, if you want to take that.
So on our small scale, we did not, you know, sort of have any dedicated new expenses. I guess we internalize a lot of that, where everyone is sort of using their personal devices from home to make these calls, or the laptops that we already have to make some of the telehealth calls. We did investigate if we're going to be really spending more time from home, expanding our telephone system and our like voice over IP phone system so that we could use those from home as well, but we never actually pulled the trigger. But I think that would be something that we'd probably consider, is having a more uniform office at home presence if this would be a prolonged situation of doing telemedicine from our house. But we did not have to expend any dollars ourselves, I believe, nothing significant.
And Jim, did your system?
Yeah. Well, we were right at the tail end of our Windows 10 rollout to our 19,000 computers in the organization. So that was a huge process, which we finished. Well, we didn't quite finish it. We were almost finished in January. And then we had, as part of that, rolled Microsoft 365 to all of our providers. So we had the infrastructure to do Teams visits once we got over the hurdle of getting patients on Teams. But as Aaron pointed out, you know, one of the unspoken parts of the medical profession is that we tend to absorb a lot of like fixes personally. We use our personal devices. We you know, stay after hours. We do things on our off time just to make it work. And so it's very easy to do that. But as a long-term solution, we are looking at building out a better in-office infrastructure for using telehealth, and that would require an investment in equipment. We did actually roll telehealth into our inpatient environment in a big way. We populated about 420 of our inpatient patient rooms with iPads to allow us to eliminate the PPE requirements for many of the visits that were happening. That way we could directly communicate with the patient in the room. We didn't have to gown up and gown off and spend all of that PPE. That has been incredibly popular with our providers, especially the specialty consultants who had to see 3 patients at one hospital, 2 patients at another hospital, 3 patients at a third hospital. And suddenly they could do that in about 2 hours instead of driving in between places. And so the equipment that we did spend money on was on the inpatient side, but I see us revamping our office staff. And frankly, there's been discussion in our network about our 300 ambulatory sites. Do we really need to have all of those real estate expenses today? Maybe we can cut 10, 20% of those and pay for whatever new device structure we put in our offices. So there's a lot of stuff on the table now where people are looking at how we used to do things, how we can do things today, and balance the costs.
So I just want to follow up. You said you actually installed iPads in each of the patient rooms. So
Yep.
there's communication between you and the hospitalists that are coming, or the specialists that are coming into the rooms.
Yeah. So like right now, I could, on my phone, I could click with 2 clicks, I could be in a patient's room at our Cole Region Hospital, Miners Hospital. And that has been really popular. I can also add a patient's family member to that call. And so the 3 of us can discuss what's happening with the patient. It's been really popular. And I see that as being just a continued process as we grow into this new paradigm.
That sounds great. Kathy, have you heard of those kind of upgrades to the network?
No, I know. I'm at University of Virginia, and we already had a lot of. We had a program called ISOCOMs, which was our isolation rooms that were technology enabled, and because of COVID, they basically expanded that like about tenfold. And I think we're seeing that everywhere. We flipped from the e-consult model, which was more ambulatory, all the way to inpatient and e-consults. For the same reason, to save PPE and to avoid having the exposure for patients and providers. So there were a lot of things that happened that did cost, but in working with healthcare providers right now, just more from the private provider side, there are a lot of platforms that are free of charge, and a lot of vendors that are offering things free of charge as a result of COVID-19. And so we actually have a list of those on our toolkit. So it's a real good opportunity for people to test and play with different platforms to see if what they like best.
We've had the same experience. There's lots of free platforms out there. We offer them. There's some that are funded through our state, so that's not been a really difficult issue for most of our rural providers.
I have one more question before Craig gives us the hook. Do you all see this whole move to telehealth continuing whenever we're through with, and who knows when we're going to be through with this, but let's say it lasts, Aaron will be dying at this, another 6 months to a year, or even until we have a vaccine and can start and live a relatively normal life. Do you think that the changes that are resulting from the implementation of more telehealth services is going to continue past that? So Jim, I'll go with you first because I know you're into the technology.
Yeah, and absolutely. I mean, one of the struggles that we've had for the last 6-7 years is saying healthcare is too expensive. Everything we do is so expensive, and this is a way to reduce cost. It absolutely impacts cost on so many different levels, and we haven't had those opportunities. Drugs don't go down in price. In fact, they keep going up in price. Real estate got more expensive. Medical school training got more expensive. So getting providers and getting access to specialties has become more and more challenging. So this is a way of reducing cost, and it's one of the massive challenges. I can't imagine that it doesn't figure into the way medicine evolves going forward, but it's going to take the government. It's going to take the government to set that paradigm, and then the payers will follow, the private payers will follow. And hopefully some private payers will see that as a competitive advantage. This payer plan offers televisits, and I hope that drives the entire industry into a much better perspective on this cost saver.
Aaron,
Yeah,
are you just hoping it's going to end?
Yes and no. No, I mean, we really enjoy sort of the social aspects of our job and interacting with patients, of course, in person. But no, I think there's definitely a role for it. So much of what we do is a lot of kind of reassurance, chart review, record review, and then people are coming to the ear, nose, and throat doctor, kind of build a plan for them going forward. It's not necessarily to repeat an exam or repeat rehash everything that's been done so far. It's really to make an educated, more expert opinion based on what has been done. So I think there's definitely a role for that going forward, continued. I don't know that it's going to be to the same level that it was 6 weeks ago, but I don't think there's not a single doctor that I know of who has not dipped their toes into telemedicine and has had at least something good to say about it. So I think that's going to continue. It's probably not going to take over every visit we have, but I would imagine it would take over a lot of visits as our 84-year-old mothers would, rather be able to answer their question with a televisit and much less transportation problems, as well as the 24-year-old with a sore throat for 3 days, maybe having a televisit with their preferred provider and, maybe, their preferred regular doctor instead of, a nurse call line or something a little bit less personal. So I think it will continue significantly going forward.
And if I could just add, it's not a universal thing by any stretch, because there are procedural disciplines that are always going to need to touch the patient physically. But look at behavioral health. It has exploded in behavioral health, and they love it. The patients love it. The doctors love it. It's just made behavioral health so much more accessible, and we need that.
Yeah. Kathy?
Yeah, I think, I don't see things returning to normal for sure. I think part of it is, this direct-to-consumer evolution has really started with kind of the for-profit sector. And we have always been saying, why aren't you seeing your own patients instead of letting the for-profit sector come in and cherry pick the easy cases? And
Yep.
I think, this has basically created the environment where all of a sudden everyone is seeing their own patients and realizing that, yeah, we can do this. And I think that is going to be a game changer.
And I would agree with Kathy on that. I think pre-COVID-19, what we were seeing is the big health systems were going after offering the virtual visits, going after a lot of the patients in these smaller rural communities, and the rural providers were not able to compete. I mean, they were, there is a great place for the health system, but there's also a place for the patient to remain with their local primary care provider. And I think this puts them on more of an equal footing platform, so that they can provide direct to consumer, like Kathy said, to their own patients, provide and seeing their own patients, so their patients don't have to find convenience in another facility. So yeah, I think it will definitely continue. I think how much it will continue, a lot will determine on how well we advocate for the reimbursement to continue after COVID-19.
Well, I want to thank all of our panelists. You guys have been wonderful, and nobody overlapped, so it was just a great range of information and a good view of what's going on in the business. And thank you again for your time today. Craig?
And thank you, Heather. What a phenomenal conversation it has been. And I'm already looking forward to the next time that we get everyone together. And big thanks to our esteemed panel, as you just mentioned, Kathy Weberly, Kathy Schwarting, Dr. James Balshi, and Dr. Aaron Rogers. Thank you so much for being part of our Broadband Bunch Zero Touch Learning Series. The next edition coming up on June the 2nd, when we talk about life post-COVID-19, a new normal. On behalf of everyone with the Broadband Bunch and ETI Software, I'm Craig Corbin. Thanks for letting us be a part of your day. Good afternoon, everyone.
Thanks, everybody.
Thanks all.
Afternoon.
Thank you.